So actually, since kind of part of the spirit of what we're trying to do here is kind of show you how we're all working together to strengthen our partnerships within and without, I wanted to have Rita come up and talk about this next piece. We're going to talk about kind of one of our big projects right now, which is working on the Affordable Care Act expansion. So Rita is my partner in crime, my assistant division chief. She's been great. I've been relying on her for everything. Luckily, she's in the office right next to mine, so I'm in her office constantly and emailing her, so I'm sorry. But she's fabulous, and I've always known Rita as Medi-Cal as well, even when I was working in the department before, so I was really excited to get a chance and an opportunity to work so closely with her and trying to move all of these projects and initiatives forward. So the next part is going to be about the Affordable Care Act work that we're doing. Rita is actually going to be project managing the Mental Health Services Division piece of it and how we fold in with the rest of the department and also within our 3 branches. So I'm really excited to have a chance to introduce you to come on up and tell folks what we're doing. Thank you.
Good morning. I am not going to talk about KDA. Those of you who know me well, it's a first. Sorry to disappoint you, Jerry, I know. And I just wanted to say this is, I've been with the Department of Mental Health 15 years, now Department of Healthcare Services. Just when I think I've seen it all, we have the Affordable Care Act, which is really exciting, and I'm thrilled to work on it. And I also wanted to say how absolutely thrilled I am as a long-term old DMH person to have Karen and Brenda on board. It's just good times at this point. Last 18 months have been a little rough and a little rocky, but I feel like we're fully integrated into the Department of Healthcare Services, and that's pretty exciting compared to where we've been. And we've done massive hiring, we're staffing up, we're gearing up. I think it's going to be much more responsive in the future, and with Karen here to guide us, I'm feeling like we're on pretty stable ground at this point, which is a place we weren't for a few months. So, as I say, good times. So the Affordable Care Act, I was thinking when we were flying up here this morning, we're missing one of our partners, which is our managed care plans, our managed care area. And I was thinking also 6 months ago, I didn't know Marlise or Marjorie, but now I can tell you every single day, every single meeting, we are all sitting in the room together and talking, and to me that's what the Affordable Care Act is really all about. And we're having that experience at the state level, and I can only imagine at the local level what that's feeling like. Trying to integrate with new partners and talk with our new folks around the table and our perspectives. So it's pretty exciting. So, well familiar, January 2014, the world will change. There will be an expanded benefit package and expanded populations. So just on your slides up here, some new services will be available through our managed care plans and the fee-for-service system. So again, psychotherapy, psychological testing, outpatient services for drug therapy, outpatient drug lab supports, and psychiatric consultation. So kind of a whole new world opening up outside of especially mental health, which really won't change a lot. So especially mental health services will continue to have the same service package that we have with outpatient and inpatient services. What will change is we'll have an expanded population of childless adults. So more people, same services, same provider network. Our world won't really change that much. But what we do have to change is how we interact with the managed care plans and how we make sure folks that we're going to be serving don't fall between the cracks. So I don't know, do we have another slide on this one? So again, some of the implementation activities that are taking place, some of you are on my radar screen to work with us on a committee we're calling the Carving Committee. And that will be a group of individuals that are with managed care plan folks, mental health plan folks, state folks are going to sit in a room and figure this out. How are we going to determine who gets served in which system? How are we going to solve problems that come up between managed care plans and mental health plans when there's a disagreement? How are we going to problem solve for folks so that we don't have individuals getting stuck in the problem resolution process with managed care plans and not getting stuck in the problem resolution process with mental health plans? So some of the big work ahead. We have to work on with CMS. We don't believe we're going to need a state plan amendment, especially mental health services, but there's a lot of state plan amendment stuff going on in the managed care world. We're trying to look at do we need, so developing reimbursement rates for what will happen in the managed care plans, new services. We have to come up with provider qualifications in the managed care plans and rates. So there's quite a bit of work going on in that area. Contract amendments, we're not sure yet if we need a contract amendment, especially mental health. We do know we need MOU amendments in the managed care mental health world. Regulations, we believe we will need one regulation change, but we're not 100% sure on that yet. The problem resolution section of 1850-505, I believe it is, needs to be amended so that we can, again, kind of tighten that system so we don't have folks fall between the cracks when we have disagreements. Quality assurance plans, we may need to look at some enhancements to what we currently do in utilization management and quality assurance so that we ensure problems are acknowledged and resolved quickly. And again, we're working on developing a beneficiary handbook. And for those of you who know me from my KDA days and documentation manuals, and I just love manuals and developing handbooks. So we're meeting to work on a handbook that will be user-friendly, something that beneficiaries can use to look at and see what's available in the substance abuse world or substance use, what's available in especially mental health, what's available through the managed care plans. And so both providers, beneficiaries could pick up this handbook and know where to go and how to get services. So, and all of this is moving at lightning speed. I can tell you it's, I think at least in one meeting a day, if not more than that, at the state level, just trying to kind of figure all this out, who's doing what. And it's really exciting. As I said, I didn't know Lori Weaver or Marjorie McKisson or Sarah Brooks, and now we're on speed dial constantly with each other. So, and I think that's probably experience will happen at the local level too, just trying to work through some of this. But exciting times and lots more work to come. So, Specialty Mental Health Services, Affordable Care Act, just call me. And my phone number has changed, and I don't even know it, so I'll have to get back to you with that one.
Yeah. Your Rita.McCabe.
Email. Yeah, my email is, I think everybody knows my email, yeah. So it's just the DHCS email at this point, but yeah, if there are questions, don't hesitate to call them. Please do be part of our work groups. This one work group we put together will meet 3 times very intensely in the next 3 weeks, but that's just getting started. We will need your participation and your help to work through this and make sure that it's user-friendly for beneficiaries and family members and that it's manageable at the provider side and the county side. So more to come.
Thank you, Karen. And I want to acknowledge the comments made earlier in the introductory presentation this morning that when the substance use disorders services were approved this year, it was a shock. It was an overwhelming shock. And it just makes me cry because I know that this group has sat through many meetings with us, heard that how limited the drug Medi-Cal services are, what such low rates drug Medi-Cal services are. The employees of these clinics make $10 an hour in Sacramento, so I think I might move to Fresno, a slightly higher wage. But truly, it's been significant and personally significant. It wasn't my doing, but it was certainly all of us and mostly all of you. So thank you, and thank you to the legislature for approving that wonderful package, removing the limits on drug Medi-Cal. So you already know, probably, what those new services are. Residential services for everyone. We had only residential for pregnant and women in the postpartum period, 2 months. I know there are issues with residential, with the rates, with the IMD, et cetera, but that service will now be available to the existing Medi-Cal beneficiary group who are in need of substance use services at the residential level. We're also adding back in what was called daycare rehabilitative services that we lost in 1997 due to budget reasons. And it's being renamed Intensive Outpatient Treatment, IOT, but that is that service that is a minimum of 3 hours per day, 3 days per week. It will be available to all Medi-Cal beneficiaries who need that level of care. We still have our outpatient drug-free services. I should hit the green button, but I got carried away. Outpatient drug-free services and the narcotic treatment services. So we have a lot of work to do. The first work that we're doing, we've engaged with county representatives to help us figure this out. Certainly we cannot do it without the counties and their providers. Catch up here. Let me get to this one in a moment. And so what we're doing with the counties, representatives and their associations, is that we're developing the overall implementation plan to be sure that we can stand these services up by January 1st. We are looking for that initial federal approval for reimbursement. That is the key. That is what everything is contingent upon, getting that okay from the federal government to pay for those services for the current population as well as the expansion population. We are closely engaged and involved with our county partners, open to their ideas for how to do this, listening very closely and actively about how it can be done, alternatives and different strategies to get there. We have a lot of issues, things to resolve, but we will be working through those lists and those activities over the next several months and then beyond January 1st. Our key thing is to get the services approved by the federal government by January 1st so that they can be paid. And you can go on providing great services to the variety of populations that we have in California. And I want to hurry up through this in order to get to your questions. So in addition to the wonderful, more wonderful maybe, drug Medi-Cal benefit that we will have in January, there are a few other additional substance use disorder treatment services that will be available. And that includes the screening and brief intervention under the Affordable Care Act. Any service and activity that the United States Preventive Task Force approves at a letter grade of B or more is to be in a healthcare plan. So that is adult screening for alcohol misuse or abuse. And so our managed care partners within the Department of Healthcare Services and through the plans will be offering this service, providing this service as part of the general health care. Let's see, and detox. Also another service that had not been available to Medi-Cal beneficiaries is actually a voluntary inpatient detox. If someone wanted to go into treatment and they needed a detox service, they really had to have something major going on with their kidney as the primary reason for going into a medical detox. Now, if someone is in that moment, that fleeting moment of, yes, I want to make a change in my life and I want to get to services, they can go in and get a detox service, and if they need that level of care, that will also be a covered benefit within Medi-Cal and in the fee-for-service system. It will be closely linked with county alcohol and drug administrators' offices for that authorization for that service. But those are all the services. Great. Yes. Okay. Thank you.
So in true form, we didn't have the PowerPoint ready in time, but I hear it's going to go on the website? Yeah. So contact information for those of you who need that. I think a lot of folks know how to get hold of us. I really want to hear from you. There's a couple of next steps I would just want to mention to get on your radar as we work through all of this, and then I want to be able to open it up for your questions and comments for the group. So, what do I do with it? So October 17th, do we know what time? October 17th? We'll get this information out to you, but just know that on October 17th, DHCS is going to have a stakeholder call, and we'll provide a status report and update on implementation efforts. And I think there's like 800, 900 people on our email list, so I'm sure you'll all be notified, but just kind of want that on your radar, that that's one of the next steps coming up. So now I really would like to open it up to you. We'd like to hear from you, comments, questions. What's on your mind? Cool, bye. Oh, okay, sorry. Go ahead. Yes, please, but there's no mic there.
I have it.
Oh, of course you do.
Hi. Bill Arroyo, thank you so much for all the information. I'm particularly impressed with the expanded substance use screening benefit. What I am a little bit disheartened about is that the benefit begins at age 18. As most of us in this room know, some of the substance use problems begin at a much earlier age, and so I'm wondering if there's any chance if that age limit can be lowered.
Is it turned on?
Is it on? Let's see, is there a button to turn it on?
Or, try now.
Yes. Let's see, where did he go? Screening of adolescents, I believe that will also be, that's probably already covered under EPSDT provisions. So the adult, that's why it's already covered under adolescent screening for substance use services or disorders would already be covered under the early and periodic screening, diagnosis and treatment service. So it would be there, and not just for alcohol, but any substance. These will be, the screening and brief intervention is a service that happens in a primary care setting. Okay?
He looks befuddled.
Befuddled. So you know that it probably hasn't happened.
I think that needs to be clearly, I think that needs to be clearly communicated through our primary care partners, because I believe that they're unaware of such a benefit. And so if you would take that up, that would very much be appreciated. Thank you.
Thank you.
Thank you. Hi.
My question is about the other thing that you talked about, Marjorie. You said there was an authorization that was going to be required for the detox service. Who would need to be doing the authorization?
Well, as the department begins to engage with the counties for the overall implementation of these services and the design of these services, we want to be sure that there is a way that the county alcohol and drug administrator's office who operates the services at the local level or contracts for those services at the local level gets connected with that person that would be in a detox situation. In the past, many people have gone to detox, but there was not a connection to a treatment service. So we're looking for opportunities to make that connection so that that individual's health care can be addressed holistically and in a connection, in a coordinated and integrated manner.
Did you have a recommendation?
Yes.
Well, I want to clarify, what kind of detox are you referring to? The screen said inpatient detox. What kind of inpatient? Are you talking about hospital inpatient?
Yes.
Yes.
Yes. Maybe it's down the
So our county alcohol and drug program services would be authorizing a medical service.
We are looking for ways that that can happen and to make that connection between these different systems so that the system is more integrated.
Okay.
Thank you. I'm Gigi Crowder from Alameda County, and we're really blessed in Alameda County to have a new AOD administrator, Tom Trabin. So he's been sharing with me a little bit of the work being done to ensure that as we have this integration, that we'll have more culturally responsive programs in place. And I'm just pleased to hear one of the individuals speak to the fact that you are using a community stakeholder process. And I'm looking at who will likely will be expanding these services to, and I just want to remind you that a large number of them will be African American males and Latino males who previously had not had these services. So we have to make sure that we have their voices at the table when we're making decisions of what that will affect them and their community. And I think we also have a unique opportunity because the AOD community has led us around how we can work with faith-based programs. And so we'll be able to learn how we can do that on the mental health side as well, with trainings and recognizing that individuals typically come with the whole community behind them. And for some communities of color, that's their faith community. So I'm looking forward and I'm excited to ESMs also being utilized to give their input around planning at the county levels. Thanks.
Yes, thank you. It is kind of an exciting time when you think of it. Hi.
Hi, thank you for your presentations. I'm Lillian Schechner, also Alameda County, Older Adult System of Care. The reason I'm up here, and I apologize if I missed your comments about this, but I did notice that the screening as well in the primary care is until 64, and is there a consideration for people over 64 to get the same service?
I don't know the answer
Or
to
65 and up, maybe to be exact.
I don't know how the Medicare age group would get that service. But I will check for you.
And not all people over 65 have Medicare for a variety of different reasons, so that may be something else to be sensitive to.
Thank you.
Thank you. Harriet?
Hi, I'm Harriet Markell from EMQ Families First. I just want to say I'm delighted with the new team of people, and congratulations to all of you, and I'm sure you're working really, really hard. So I have a question about dual diagnosis. So far, all of the conversation has been about drug and alcohol treatment, mental health treatment. And clearly, we all know that both for kids and adults, that many, many, many of our clients are dually diagnosed, or if they're not so kind of formally, they probably ought to be. And that we need to have treatment availability, we need to have billing availability, we need support for providing that kind of care. And I wonder if anybody's been thinking about that, if there's any planning going on.
I would say yes. I think co-occurring is something that I'm well aware of and very passionate about, and I think that's why, one of the reasons why the legislature wanted to move these two departments together, so that we are having those conversations. So thank you for your comments.
Great.
I don't know, can we just skip Alan, go right to Richard? No, I love Alan. Everybody knows I love Alan.
Good morning, Dr. Baylor and your staff. Don't have much chance to speak, so I want to take the opportunity. As one of the dinosaurs in the room, along with my other dinosaur right behind me, I wanted to make a statement, and I felt so good when you talked about inclusion, transparency, and collaboration and partnership. It's something that I think we look forward to. The tone of the presenters really talks about partnership and everybody working together, and I just really appreciate this is a new time and a new era, and your leadership along with your staff, it's going to be tremendous. One suggestion.
You taught me well.
Well, thank you. I appreciate that. One suggestion. Tina's not here, but I was wondering about having some identity in your department in regards to consumer empowerment, consumer affairs, having some of the consumers who could then work closely with the consumer groups, I think would be just another way of demonstrating your vision of inclusion and collaboration.
Absolutely. I don't know the mechanism for doing that, but I would love to do that. And let me just tell you my one Alan Rollins story. So I wasn't even working at I was working in a private nonprofit, and it was right when they were rolling out MHSA. And we were in this big, huge meeting, and this guy rolls in, and everybody seems to know him. And I'm like, who is this guy? And so then I'm at some other meeting, and everybody seems to know him. And finally, I got the pleasure of being introduced at CMHDA and thought, oh, that's who that is. So I appreciate all of your experience and knowledge. And dinosaur, historian, You know, you've got a lot to bring to the table, and I just really appreciate all your mentoring over the years. So thank you.
And good luck.
I'm going to need it.
I think, I wanted to just hold Alan here for a second.
I got to hold him up. He's over.
We've been dinosaurs together for so long, but we started out in terms of the advocacy game doing a cheerleader kick line back in 1981 or 2, the last time we had a major budget crisis, with our megaphones and cheerleader outfits to get folks to think we can do things, we can do what we need to do.
Mr. Van Horn, that's just scary. The visual there is just... I can't go there.
The question I wanted to ask is also part of the statement, and I'm delighted that we have a true data diva in the leadership team. Yes! We have outcomes for the full service partnerships developed originally at AB 3777 and Realignment 1. We don't have outcomes structured for the rest of the world.
Yep.
And we need to have that.
Yep.
And I think that the state auditor pointed that out most painfully to all of us. And as current chair, and I hope for one more year, chair of the Mental Health Services Oversight and Accountability Commission, we would like to not challenge you, Karen, but encourage you and Brenda and the rest of the team and to include the substance use side so that we get a reasonable set of outcome expectations so that we'll know when we're doing it right and we'll know what we need to do to improve. So I think that's a major piece that needs to happen. Thank you.
Thank you. Thank you for your comments.
Hello, my name is Jessica Vieira. I'm from Sacramento County. And my question is about Medi-Cal and minor consent Medi-Cal. So if a family is currently on Medi-Cal and the minor is asking for treatment for substance use disorders and does not want the parents to know this, is there a way to amend any statement of benefits so that the counties do not absorb the cost through minor consent? Since this is an eligible service for this child.
Anybody?
Minor consent services are available to that youth, be limited to the outpatient drug-free, and I believe that other counties have been authorizing and continue to authorize minor consent services across the state, maybe just a handful. I can connect you with another county that does that. I know that if a youth is coming in and wants those services confidential from their family, they get a different number, Medi-Cal beneficiary ID number, and their parents would not be aware of those services unless the youth informed their family.
Then could that cost of that service be claimed through the parents' Medi-Cal versus the minor consent? So is there a way to combine those two so that the burden is not to the cost of the county? That's my question.
No.
Any thought about having it done?
If he or she, it is a state-only program, it's a state-only law, it's not a service that's authorized under the Medicaid, so it's a state-only program. Realignment.
All righty. Any other questions, issues? Guys, let us off. Oh, okay.
Jim Waterman, Kern County. I just heard the comment about inpatient detox. What's the future for social model detox approaches?
Those services are currently, well, conducted in a residential setting, and it would be billed as a residential service. I want to say that under the Affordable Care Act, and as California goes forward, we have to amend our state Medicaid plan. That state Medicaid plan is up on the DHCS website. There's content in that website, in those state plan pages, that are just somewhat descriptive of the services, but it doesn't go to the level of detail that says this residential service is a detox service. So it's residential, here are the services, etc. That's the current level of detail on those pages.
So what you're saying is that eventually that it is a billable covered Medi-Cal service if it's covered as a residential service rather than a quote-unquote detox service. Is that?
I will be working and listening to the counties on that issue and confirming that that's how it is.
All righty. Any other questions? Comments? Yeah, Suzanne. Be gentle.
I am very gentle. So this is following up on this, since we're just now talking with the mental health side of the DHCS house about coming up with certification understandings, requirements, and along with the certification requirements, building out sort of a grid about what each program needs to do in order to be certified, and in the range of services that can be provided and are not lockouts, et cetera. Do you think it might be something that we could do on the substance use services side as well?
Absolutely. I think we're very interested in doing that, and in some internal conversations wanting to be able to standardize. And it does make sense to have some integration there.
Thank you.
Oh, sorry. Mike. They're not going to be able to hear you. Can you hear them? Can you hear me?
I'm Marty Giffen. I'm with ANCA Behavioral Health and also the president for California Mental Health Advocates for Children and Youth. And I'm just wondering, I know things are moving at light speed, and but I'm interested in if there's a point person in your personnel structure that will take the lead for children, EPSDT, but not just including EPSDT, but other service oversights for children and adolescents.
Can you give me more? What are you looking for? Just.
Well, I see that Brenda is in mental health. Under Brenda, might there be a specialist or somebody appointed as, in particular, looking after children's programs, overseeing the EPTSDT?
I don't think we have anyone designated in particular, but you can contact me, and then whatever questions you might have, I can triage, or Rita and I will both work to get you to the right person that you would need to talk to.
I think a lot of you know Dina, who's been really active in the KDA conversations and has a lot of knowledge, who works for Brenda as well. But yeah, I think you can start with Brenda. Yeah.
Thank you.
Oh boy.
Oh, so Karen, I just want to share, I'm on an advisory committee for SAMHSA for children's mental health. One of the criticisms coming out of SAMHSA is that there really isn't a lead in behavioral health for children. There's usually a go-to person in each state for children's used to be mental health, but of course many states are broader. So it's something to think about, just because there's policy issues that Bill Arroyo elaborated on, Marty cited. So I do think it's something to think about, just in terms of having that point person. So
that's helpful. Thank you. All right. Oh, Al.
Thank you. I'll be very brief, but I wanted to comment on the detox piece, because it almost sounded like a decision was made about how that process would play out, and I don't know that that was accurate. But Marjorie, when you first opened up, you mentioned that it would remain in the fee-for-service system, but authorizations would run through counties. And while I support the point about making the connection in terms of ongoing treatment, and that piece is there, I caution with one government entity giving the authorization and a separate government entity being responsible for the payment, the problems that might arise out of that. So I wanted to put that out there. Two other points that were raised, that the Medicare does already reimburse for the screening and brief intervention stuff, that they authorized that some years ago, so that is correct.
The EPSDT point, I think, is really the issue that comes up around audit. So often when you do that brief screening for substance use, you'll find auditors that say, where's the connection to mental health? So I think that's one of the problems.
Okay, thank you. We'll take a look at that.
One more question.
Absolutely.
This one's really far afield, so probably it's just totally out there. But in our county, we have 2 large FQHCs that are authorized to do behavioral health services. And I understand those are separate entities and tracks and authorities and so on. But I'm just wondering what coordination is possible between state Medi-Cal and FQHC services, because what we have developing are different definitions, different responsibilities, but it's also a situation where we have an entity that's providing services to a certain point, and then if they're unsuccessful, they fall into our system with no real background or involvement by us in those services as FQHCs develop along these lines. So it is of concern to us as the Medi-Cal entity and provider, what happens with FQHCs. So I don't know the lay of the land, who's responsible, just wanted to kind of mention that and ask what coordination can develop between Medi-Cal and FQHCs. I'm particularly thinking of seriously mentally ill mental health beneficiaries who will be seeing psychiatrists in FQHCs in my county, and yet when they go in the hospital or decompensate, all of a sudden become my responsibility.
Okay, thank you.
Shumitra Sengupta, I'm with the EQRO. Actually, I'm following up on Richard's comment a little bit about, and I'm really excited about Brenda's being the mental health division chief because of all the outcomes and performance measurement experience that you bring to the table. Last year I was at a national conference where Mathematica Policy Research Institute was presenting on evidence-based treatments. And it was kind of shameful to see that California's line was blank. They looked at 46 states, not 50 states, 46 states, and California was the only one which completely blends out its data that it submits to CMS. The evidence-based treatment piece that is captured in CSI is not transmitted to the federal level. So when CMS funds a study, it doesn't capture California providing any evidence-based treatment, which was kind of shameful because I know we go to every county, and every county has at least one, if not more. Even the smallest counties have evidence-based treatment practices. I think capturing those and submitting that to the feds would be really helpful.
Thank you. That was way beyond my knowledge base, so Rita, you got that? Yeah. Thank you. Yeah, you had your turn.
I'm back. But Karen, as you know, in one of your many previous lives in county land, as you often say, we're challenged by folks being released from prison and their benefits. And I know from being appointed by the Speaker of the Assembly to the California Rehabilitation Oversight Board, as we look at their quarter statistics in terms of percentage of folks who are coming out on benefits, I have noted over the past 4 years that they are successful at having Medi-Cal benefits to the tune of less than 2% in those that are eligible. And so what I would like to know is, to which degree are you working with CDCR and social services to ensure that as many folks coming out of the prisons to county land get on Medi-Cal?
That's that committee you were on yesterday, right, with Rita?
Waiting for you to attend with me, yeah.
And I think I turfed it over to Brenda because, you know, she worked at CDCR. So
So now you get it back.
no, thank you. I don't know, do you want to respond that we're working with CDCR?
I mean, I know I've brought that up in our work groups, because coming from CDCR just, in July, so I know it's a huge issue. And I know there's pre-parole planning, and it's that linkage with the CDCR folks, and I don't know enough about how this Department of Healthcare Services is going to interface with that.
Yeah,
But I think that's an issue. I think it's a great point.
We have an opportunity with Affordable Care Act.
Yeah.
Because it doesn't cost you a cent.
Right.
And doesn't cost us a cent.
Yep.
So why don't we make it work?
Yeah, we were actually talking about that, I think, in the airport this
So,
morning.
I would just...
Bill, have you met Brenda? You guys could...
Sure, I grilled Brenda when she's been over there. Any chance I get, I will grill somebody. You know that, Karen.
I would just add that on our contacts page, we also included the contacts for the DHCS's deputy over benefits and over the managed care plans. And I know that they would be lead for that connection to get those persons qualified for Medi-Cal before they are released.
But it's that linkage, I think.
It's that linkage, yeah. Okay, thank you. Yes. Bill broke the mic.
Yeah.
No,
Good morning.
there you go.
I'm Donnell from Shasta County, and we have 4 federally qualified health centers in our county, and my understanding is right now, the drug and alcohol situation, they have to have a licensed person do individual counseling. They can't do groups, and I was wondering if anything is changing with these new substance abuse benefits that will expand what federally qualified health centers can do and claim for.
I'm not really sure.
We don't know.
I don't know. Obviously, the individuals will have the coverage, but Drug Medi-Cal has been separated out and operated as a separate system for so many years that within their an individual's Medi-Cal coverage, they would have those SUD benefits in Drug Medi-Cal. FQHCs do not provide, quote, Drug Medi-Cal services. They provide a separate behavioral health SUD service. So it's up to those individual FQHCs as to what the services that they agree to provide and what they agree to having in their, it's not an all-inclusive rate, but it's their rate, the social service,
The
their
PPS
scope.
rate?
No.
I think that needs some more thinking because
Yes.
we're trying to integrate mental health and substance use disorder treatment with primary care, yet there seems to be a disconnect there. And it seems to me if we could get more of those kinds of treatment opportunities in the FQHCs, they wouldn't have to develop partnership with other organizations as much and just get it all in one place.
Okay, thank you. We only have a few minutes left, so we're going to need to...
I'll go very quickly.
Thank you.
I'm Paul Taylor from Momentum for Mental Health in Santa Clara County. I'm a CCCMHA board member. I'm very concerned that Medi-Cal reimbursable residential treatment programs are licensed by the Department of Social Services rather than DHCS. So I wonder if this is an issue you're willing to explore. I know there's been advocacy on this for decades. And what might be some of the obstacles that need to be overcome for this to happen? I think this has always been important, but it's especially important with Steinberg's recent efforts to increase the opportunities to provide crisis intervention on an outpatient basis, but also in crisis residential treatment programs.
Anybody want to comment? We don't know. We'll look into it. Thank you.
Hi, Jose Oseguera, Mental Health Services Oversight and Accountability Commission. Just curious to know what is being done to formalize the issue resolution process.
Which one?
The one that we have for counties and just various different complaints that are raised to the state as well as at the county level.
Do you know, MHSA? I know each county has an issue resolution process.
But there's one that's, and
The state has one as well.
I'm waiting to be briefed on that, so it's been brought to my attention that this is something on our plate, so I think I have a meeting next week with my staff so they can give me the lowdown on it, so I'm not quite sure where it's at in that process, but I can definitely, and I've talked with Aaron. I think Aaron just asked me about it about a week ago, which is what prompted me to ask my team to get a briefing, so.
Terrific, thank you.
No, thank you.
Steve.
Steve Kaplan, San Mateo. Just kind of a comment, although we're ecstatic with the expanded substance use benefit, there are some limitations still, what didn't kind of take us the whole way. So I think it would be useful for the department in collaboration to really look at what's still missing, the ability to provide services over a longer period of time outside of a primary treatment setting to support people's recovery, and certainly looking at an expanded acceptance of medication-assisted treatment outside of methadone, I think is really a critical piece to look at as well.
Thank you. And we're running out of time.
Okay, I'm going to be brief. I just want to identify myself. I'm Sarah Eberhardt-Rios, and I'm another data diva. So Brenda, I want to let you know you got people. So just want to encourage the department to advocate for the data analytics staff you're going to need to accomplish this great goal around data analysis, sharing, and performance outcome measurement. It's going to take hundreds of folks, and just to allocate the right amount of time to connect with county staff, really looking forward to you creating that infrastructure, and we want to plug right in with your data analytics staff, so thank you.
Thank you. We want to do this right. So yes, you two need to connect.
Yeah.
Hi, my name is Leslie Preston.
Oh, sorry, it's just one thing. We're in the process of, our data team just got established in our office in April. So we just have a new manager too, who just started, and she's in the process of filling the entire data shop up. So if anybody knows of anyone, I know CDCR has an open list that they are always accepting applications for. You can email me, I'll get folks connected up, because we're always looking for talented, great new people to join our team. Sorry, that was a little plug. Go ahead.
Hi, I'm really excited about the health plans requiring screening in primary care as a way to identify. I'm very concerned about the response that under 18 is an EPSDT benefit, because the reality is that the primary care clinics have no mechanism to actually bill for that. The time it takes to put somebody onto the system to bill for EPSDT is more time than the screening actually is. So unless we find some way that they can bill the same way they bill the adults and maybe transfer the money, but to think that screening is going to happen in primary care by every youth that goes in there getting individual episodes open to bill a 15-minute screening is really not going to happen. So I would invite some consideration of how we can actually make that work.
Okay, thank you. Last comment, question.
Okay, I had a really quick question around our cultural competency plans.
I was waiting for that.
Yeah, well, I thought about it, and then I thought maybe not, then I thought why not? So I was planning on leveraging a pay increase with the great approved plan that we would have had we had it scored, and then the shift happened from DHCS. Anyhow, have you guys made a decision about that? I used a really broad community stakeholder process. Coming from Alameda County, we have such a diverse county, and a lot of the folks I used are waiting to hear the results and where you're going. So I'm hoping you have a response I can take back.
I wish I did, but it is on our radar, and we are having some internal conversations. I think it's in Dina's shop, and we know that there's some folks anxious to get us to make a decision and move forward with this, because we know it's very, very important. So I don't have anything for you today. Hopefully very soon.
Great, thank you. Look forward.
All right, thank you all very much. Enjoy your day. It's been a pleasure.
Well, Karen said she got a list of about 350 items to work on from her staff, and I think you just got another 100, so up to 450. We're going to take a break. See you back here at 10:30.